Hello, my name's Sarah. I'm an anaesthetic registrar, and over the next 5 minutes I'm going to take you through TEG. I think it's a really good way of treating patients who are trying to bleed out in front of you by normalising any coagulation abnormalities. Really quick to go through, so we're just going to jump straight into that right now. So the beauty of TEG is it is simple. I am simple, TEG is simple, suits me down to the ground. So there's basically only 3 things that we need to look for on a TEG trace. So one is the R time. So this is telling us about clot formation. If your R time is more than 10 minutes, your patient needs more clotting factors to help them form that clot, so they need FFP. Next couple of indices we're going to take note of but then ignore completely. So there's something called an alpha angle and a K time, and this is just telling you how quickly that clot is developing. So we can note those down and we can know what they are, but it's not as important as the next thing, which is our maximum amplitude, or MA. So MA is the maximum amplitude of your clot. That's telling us how strong the clot is. So the maximum amplitude is all about clot strength, and that should be 50 millimeters. If it's less than 50 millimeters, your patient's going to need something to help them have a firmer clot, so platelets essentially. If the maximum amplitude is less than 50 millimeters, your patient needs platelets. Next thing is the stability. So something called the Ly30 time, which is how much your clot has lysed, so lysis, after 30 minutes. If it's more than 8%, they need TXA, tranexamic acid. Okay, so now we've gone through the R time, which is all to do with your clotting factors. If it's prolonged, they need FFP. We've got the maximum amplitude, or how strong the clot is. If it's reduced, they need some platelets, and we've got how quickly the clot is breaking down, over 30 minutes. So if it's greater than 8% is broken down, they need some TXA. Just very quickly, I'm going to go through why does it have 4 traces, because I think this is a bit that people come unstuck on and why they get confused. So essentially, each of the different traces has some slightly different reagents. If we can understand what the reagents are there for, we can understand what each of them is good for. So the first one is your bog standard trace, and it's called C for citrated because it uses citrated blood, so in a coag tube, and K for kaolin. So kaolin is a bog standard reagent which is added to the sample to help the clot start to form. So this is the trace that's going to tell us all about the R time. It's going to have a max amplitude. It's going to show us the kinetics of clot breakdown initiation. So this is the standard trace, but the really important thing to get from this is the R time. Okay, so what's the purple one then? Why would we have a purple one? So this is something, again, it's got C for citrated, and then it's got 2 letters, RT, so that stands for rapid TEG. So this one's got some tissue factor in. Now platelets love tissue factor. It's going to set them off like mad, even if you don't have any clotting factors. So what's the use of that? Well, it's going to give you that maximum amplitude we can see here that much sooner. So you don't even have to wait your R time for that clot to start to form. It's going to cut out the middleman, and it's going to give you your maximum amplitude about 10 minutes sooner. So you have a patient that's bleeding and you want to know whether to give platelets, you look at the rapid TEG, you look at the maximum amplitude, and you work out whether you need to give some platelets. What's this skinny little blue one? Well, this one is something called the C for citrated again, and it's got 2 letters, FF, so that's for functional fibrinogen. So this one's all about your fibrinogen. It's basically got a load of antiplatelet agents in it. So it's inactivating all the platelets, so it's stripping off those platelets, and it's just showing you the fibrinogen contribution to the clot. So this should be greater than 14 millimeters. If it's less than 14 millimeters, your patient needs more fibrinogen, they need some cryo. Okay, last but not least, we've got something called the CKH. So the first 2 letters are just the same as the kaolin trace, so it's citrated blood, it's got kaolin added to it, it's got something else, it's got heparinase. So this is showing you what it would look like if you stripped away any heparin that you've given the patient. So a lot of the time, if you haven't given your patient any heparin, it's going to be exactly the same as your kaolin trace. It's going to look exactly the same. If your patient's got heparin on board, then this trace is basically showing you what would happen if you reversed all that heparin. So if you took away all of the heparin from your patient from this trace, it's showing you what would be left behind. So we can see now it's very simple. There's only a few things we can do. Is the patient's R time prolonged? So if it's longer than 10 minutes, they need more clotting factors, we give FFP. Is the maximum amplitude down? Maximum amplitude's down, need a stronger clot, need more platelets. Is the functional fibrinogen low? If it's less than 14 millimeters, get out of the cryo. And that's all there is to it. Thank you very much.